Hi, I'm Dr. Joe Pelerin, and I have been practicing general dentistry since 1973, principally in Auburn Hills, Michigan, with an emphasis on operative dentistry, largely crown and bridge, and cosmetic reconstruction. During that time, I, like most dentists, have seen many patients suffering from bruxism. Over the last few years, I have seen a dramatic increase in this malady. However, during and following the COVID pandemic, I have seen an even higher incidence of this problem. And with the stresses that everyone faces, it is the most extreme I've ever seen it. I have heard other dentists describe this as an epidemic. While many dentists recognize this problem, I believe many others do not give it proper weight when examining new patients or even recall patients. As I will point out in this course, there are many easily recognizable signs for dentists to diagnose this problem. However, even if you don't see any of these signs, you'll be surprised if you ask the patient, "Are you aware of clenching or grinding your teeth?" How many will say yes if you ask them, but if you don't ask them, very few will volunteer this information. Even if diagnosed, by far the only treatment most dentists offer is the traditional full arch splint, which has been available for over 100 years. This treatment requires at least 2 appointments, impressions, and laboratory fabrication costs, which many patients will not accept, or referral to a TMJ specialist, which can cost thousands of dollars and still may not leave the patient with a long-term solution. Offering the patient a right-now solution that is affordable, easier to wear, and able to reduce muscle activity, which is the main cause of the problem, is a valuable treatment option most dentists could benefit from having in their treatment options. Furthermore, along with treating patients in my practice, I am also a patient myself. Over 30 years ago, I began to notice shoulder, neck, and headache pain, so bad that I went to the hospital and had an MRI taken. They could find no reason for the problem, and it was suggested that I simply take pain medications. Even as a dentist, I was totally unaware that I was clenching my teeth. I had no tooth pain or jaw pain at all. Finally, I got a little pain in my left TMJ. I made a splint and found out that my shoulder and neck pain were alleviated. This was the beginning of a passionate journey to learn more about bruxism, the temporomandibular joint, and treatment modalities. I took courses from many experts with different points of view, as I treated my own patients and undertook my own treatment with the help of some local specialists. In the following CE course, I will present a basic description of temporomandibular joint anatomy and pathology, and the relationship between the temporomandibular joint and muscle pathology. It will also encompass the various forms of tooth damage and head and neck pain that are related to this problem. On many occasions, the public at large and even some dentists refer to any of these problems, lumping them all together. He or she has TMJ. Well, everyone has 2 TMJs. It has become a catchphrase to describe any problem with clenching and grinding, tooth damage, head, neck, or joint pain. And I will point out that while TMJ pathology predisposes people to bruxism, head and neck pain, etc., in my opinion, it is not all about the joint. In fact, it is more about the muscles. We will address the pros and cons of a number of contemporary treatment modalities. To begin, let's look at basic TMJ anatomy. The temporomandibular joint is at the base of the skull, just in front of the ear. It consists of the glenoid fossa concavity that ideally is the distal resting place for the condyle or head of the mandible. Between the condyle and the glenoid fossa is the articular disc, a fibrous extension of the joint capsule. It is a meniscus-shaped. Ideally, the disc travels with the condyle during opening as the condyle travels away from the joint and down the eminence. The 3 main muscle groups in play are the masseter, the pterygoids, medial and lateral, also the temporalis. There are many types of pathology in the joint. They include arthritis, calcifications, bone spurs, flattening of the head of the mandible. By far, the most common problem is anterior dislocation of the disc. This video will explain this simply and clearly.
The temporomandibular joint, the TMJ, is the joint between the lower jawbone, the mandible, and the temporal bone of the skull. The TMJ is responsible for jaw movement and is the most used joint in the body. The TMJ is essentially the articulation between the condyle of the mandible and the mandibular fossa, a socket in the temporal bone. A unique feature of this joint is the articular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center and is therefore insensitive to pain. Anteriorly, it attaches to the lateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 millimeter opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc must move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful, as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc is an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back end of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. In a later stage of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction. Fortunately, in the majority of cases, the condition resolves on its own after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it's called a pseudodisc.
There are various forms of TMJ pathology, and the video explained the most common problem. With the disc out of position, the muscles try to keep the fossa and condyle in contact, but work overtime because the disc is not between them anymore. However, does everyone with bruxism need to have joint pathology for them to clench and grind? The numbers don't add up. Many estimate that at least 30% of the population suffers from bruxism. The ADA says up to 95% of the population suffers from bruxism at some point in their life. A February 2020 poll by Dentaltown indicates that 63% of those that suffer are between 35 and 55 years of age, with another 22% between the ages of 18 and 35. The same survey, 38% of dentists have noticed an increase in young patients who have been previously treated with orthodontics. Some estimates of people with TMD, or temporomandibular joint disease, are 10 to 12%, and I think that is high. It's clear the number of people with bruxism problems don't all have joint problems. I believe people can have perfectly healthy joint, and with enough stress, they will brux. Now let's look at the problems that are related to bruxism. One of the most common and easily recognizable problems related to bruxism is wearing and flattening of the teeth, both anterior and posterior. If a patient is not aware that they are clenching and grinding their teeth, the dental professional can easily see the wear. This is an ongoing problem. The patient should know if they don't do something to intercede, the problem will continue, with more teeth damage likely, and pain may also result. This will also result in more dental work being required. While tooth fracture and fracture of restorations can occur during chewing, especially when biting on a hard object or hard piece of food that you don't know was there. Clenching and grinding of teeth is an increasing problem that can cause tooth damage even while you're sleeping. Gumline notching of the tooth. Many have attributed this gumline notching or ab fracture to toothbrushing, and while this may have some effect, more and more professionals understand the notching relates to tooth clenching. As jaw muscles contract and the teeth are forced together, the root of the tooth is held in the bone. It can't move, but the tooth can flex, and these flexural forces are manifest mainly at the gumline, causing minor chipping or ab fracture at the gumline. Generalized tooth sensitivity, typically to hot and cold, with no underlying dental cause. Many patients will come in and say, all my teeth are very sensitive to hot and cold, and they don't have any dental problems. Same issue as described in root canal treatment, with no apparent cause evident in these people. Clenching or grinding can push the roots into the socket. The circulation on the tooth is the worst in the body, very poor. When pressure is put on the blood vessels at the end of the root, there can be inflammation, preventing proper blood supply to the tooth. The nerve's reaction to this is angry, typically sensitive with hot and cold. Extremely tight cheek muscles and inability or difficulty to open or hold open. Again, many patients who may be clenching or grinding and not be aware of it have very tight musculature. The dental profession can pick up on this during routine exams and have follow-up questions to see if intervention is appropriate. Shoulder and neck pain. This is harder to understand. How can clenching of jaw muscles cause shoulder and neck pain? As your muscles contract, it can cause a reflex contraction of the shoulder and neck muscles. I call this musculoskeletal reflex contraction. I experienced this in another part of my body when I pulled cartilage in my chest directly over my heart, a very frightening, intense pain. But by the end of the day, the pain had traveled 180 degrees to my back. As the muscles in my chest contracted in response to the torn cartilage, the muscles on the other side had a reflex contraction. The same thing happens in the head and neck when the jaw muscles contract. A reflex contraction can happen in the shoulder and neck. Headache pain. This is the same concept of reflex contraction that I described. As the jaw muscles contract, it can cause contraction of muscles in the temporal area or in the back of the head as a reflex contraction or balancing contraction to the jaw muscles. The people that make Botox understand this, as Botox is used for migraines. They inject the jaw muscles with Botox, and this can prevent the contraction of the muscles in the head that cause migraines for many people. After describing some of the maladies relating to bruxism, I think it's important to show how my staff assist me in diagnosing and treating these problems. The following interview with my hygienist will show how this is a team effort.
The top signs that I see are usually occlusal wear, the tight musculature when you go to pull the teeth or limited opening.
Yeah.
Also, I see a lot of the notching at the gum line, the ab fracture,
Yes.
wearing away at those teeth.
Yep. Yeah, as they flex under the pressure, it causes that. A lot of
Yes.
people don't recognize it. It's not they used to think it was toothbrush wear, but most likely it's clenching. And she tips me off, and that confirms it. Because just like if we're looking at a crown or a restoration, she finds it, I confirm it, and the patient goes, "Oh, gee, they both think that." And so I'll come in and I'll look at what she'll tip me off, and I'll say, "Yep, I think this patient is bruxing," and it's a more confirmed diagnosis. Treatments. We have talked about the many symptoms and problems caused by and related to clenching and grinding of teeth. Now I want to discuss the various treatment paths and devices that are available to us and our patients. Physical therapy. This can include several modalities, including massage therapy, heat and cold therapy, stretching, ultrasound, stretching of individual muscle groups, referral to the dentist for an evaluation of teeth and occlusion problems. Chiropractor and acupuncture therapy is sometimes employed. Botox injections. Many of you have seen Botox commercials for migraine headaches. However, these commercials don't explain how and why Botox is used and how it can prevent migraines. Some of the main injection points for Botox are the masseter, the temporalis, and the pterygoid muscles. the muscles that help the jaw close. The people that make Botox understand that as jaw muscles contract with great intensity, it can cause a reflex contraction in the shoulder, neck, and head muscles. This can lead to the migraines. This is a point I have made before and will come back to shortly. Reconstructive jaw surgery. This is an option I considered during my own personal treatment. In my case, it would have consisted of sectioning the maxilla into the anterior and 2 posterior segments and resection of the mandible. The goal is to reposition the maxilla and mandible so that the muscles and joints are in harmony and the teeth are in position to support both. Sounded extreme to me. The surgeon said, "It's really not that big of a deal," and it probably isn't for him. Then I asked a colleague whose assistant had the procedure done. She was 30 years younger than me and was just getting started back to work after about 8 weeks. Orthodontic treatment. This is done to reposition the teeth so that they will be in better harmony to support muscle and joint comfort and function. This is particularly important for children if a child is having problems with bruxism, jaw pain, joint pain, headaches. It should be particularly considered during the pubertal growth spurt when orthodontic treatment is best done. Prosthetic reconstruction. This is ultimately the course that I chose for my own situation. It's important to note myotronics was used to find muscle harmony for reconstruction. This jaw position often will not match the previous occlusion. The old adage, if you have a hammer, everything looks like a nail, comes into play. Every specialist may think he has the best solution, but in fact, the solution varies from patient to patient. At the beginning of the course, I talked about my unique perspective as both the doctor and the patient. Now I'd like to come back to that and show you how I was reconstructed prosthetically with a full mouth reconstruction. When I was in dental school and opened my mouth, there was a pop on my left TMJ that could be heard 20 feet away. But other than noise, I didn't have pain or functional problems until I got into my 30s. I had no tooth pain, but shoulder, neck, and headache pain I had so bad I had an MRI taken at a local hospital. They had no clue as to what was wrong or why I was in pain. Finally, I got some pain in my left TMJ, the one with the anterior displaced disc and the pop. That started my journey and taking courses from different points of view, treating my problems with the help of local specialists. As I previously mentioned, I considered the surgical option, which would have required sectioning of my mandible bilaterally and maxilla into 3 sections. The surgical option would have provided repositioning for the muscles and joint. However, at close to 60 years old, the time for healing, taking away from my practice the possible negative sequelae such as paresthesia, etc., I decided to go with a prosthetic rebuild. This is the lateral head x-ray of myself after reconstruction from a local prosthodontist. Again, with the aid of myotronics and computer tracking, he was able to find where my muscles would be most comfortable. I was originally a Class 2 Division 2 occlusion, with my mandible forced back too far into the joint and my vertical dimension overclosed. With myotronic guidance, my vertical dimension was open about 6 millimeters and my mandible was advanced about 7 millimeters, and lower splint was then formed, which I wore 24/7 to be sure this new jaw position would be functional and comfortable. I was then rebuilt prosthetically with crown and bridge. This position, as you can see, the condyle is halfway down the eminence, not close to my joint, and my joint is not angry with me. In fact, it is quite happy, and so are the muscles. My left TMJ, with anterior disc displacement, no longer pops and clicks. I have normal range of motion, and I'm pain-free. My main point is that sometimes muscular harmony and skeletal anatomy don't always match, and it's more about the happiness of the muscles than the joint. Having said that, even with perfect TMJ anatomy and muscle harmony, I think with enough stress, virtually anyone can suffer from bruxism. Therefore, in these stressful times, there are many, many people that could benefit from some type of splint therapy to protect their teeth and prevent joint, neck, and head pain, especially during the night. These days, many of us clinicians are recognizing, testing, and then treating obstructive sleep apnea, OSA, either with lab-fabricated mouth guards or CPAP. I have a number of patients that wear a dental bruxism appliance for bruxism while wearing the CPAP. Studies suggest there is a distinct two-way relationship between OSA and sleep bruxism, but the coincidence is not a one-to-one relationship. On the commonalities existing between OSA and bruxism, are they related to upper airway obstruction, whereby bruxism may be a normal physiologic reactive protective mechanism? If so, sleep bruxism can be utilized as a reliable and valid surrogate clinical marker for OSA. A study at the University of Houston Medical School assessed the prevalence of bruxism and GERD. Among 300 people with OSA, they found that 25.6% of these patients also suffered from bruxism. The incidence was higher in men than women, and higher in Caucasians than any other group. According to the president of the American College of Chest Physicians, sleep disorders such as sleep apnea can lead to many secondary health conditions. So when treating sleep apnea, clinicians must also recognize and address secondary health conditions, such as bruxism, in order to fully manage the patient's sleep disorder. While this CE course is focused on bruxism, we should be aware that many patients who report their OSA should be checked for signs of bruxism and vice versa. Confirmation diagnosis of OSA involves sleep monitor testing, and degrees of severity are multiple. The clinical signs of bruxism are very apparent to every clinician, and the bruxism can be treated immediately to relieve the pain. By far the most popular choice of treatment for bruxism is orthotic appliances. There are a wide variety of appliances to treat bruxism, an almost never-ending choice of new appliances, but in this course, I will focus on three. The full arch or horseshoe appliance, which can be made for the upper or lower arch. The NTI, which stands for nociceptive trigeminal interrupter. The GrindRelief PRO. The full arch horseshoe appliance, which can be made on the upper or lower teeth, is by far the most popular choice among dentists. It has also been around longer than any other appliance, over 100 years. Typically, this is what has been taught in dental school. However, most students have very limited exposure to any treatment of bruxism. The full arch appliance requires upper and lower impressions at the dental chair and a bite registration. Typically, these impressions are sent out to the lab, and in a week or two, the appliance comes back and needs to be fit at the chair side. First, the appliance must seat totally and have retention. This sometimes requires adjustment. Then, the occlusion has to be checked. Make sure that we have even contact on all the teeth and be sure there are no prematurities in excursive movements. I have made countless numbers of these over the decades I have practiced, and also worn this type of appliance myself. Studies show while this is plastic between the teeth preventing wear, it actually causes the muscles to contract with more intensity. If normal clenching is 100%, you might be at 105% with an appliance like this. I listen to my patients, and after numerous complaints that this is just too big to wear, I can't wear it, it's not comfortable, and it costs way too much, I had difficulty with my patients accepting the treatment. Also, people tend to wear these appliances sporadically, sometimes leaving them out for a while. And when they go to put it back, it won't fit and cannot adjust this. If there is even slight tooth movement while not wearing the appliance, it will not fit again. Efficacy or effectiveness of treatment, time delay in providing the device, and cost caused me to look at other options. The NTI, which stands for nociceptive trigeminal inhibition, is a small device fitting on the anterior 2 to 4 teeth with a central bar rising up from the plane and contacting the midline of the opposing arch. This device has been used for over 20 years and has some great success, but also some shortfalls in my opinion. The device can be made chairside, but the favored way of doing it is just to again take impressions, send it to Keller Laboratory to make the appliance there. They have studies that show central bar pressure on the opposing midline can reduce muscle activity 60 to 70% or more. Also, it's the only appliance I know that has shown efficacy with migraine headache sufferers. 85% receiving relief from migraine symptoms in a study with FDA clearance. This device is more wearable than the horseshoe and more effective at reducing muscle activity, but it also, in my opinion, has some problems. The central bar that rises above the plane and interacts with the opposing midline is very effective for most people and helps reduce muscle activities, as studies have shown. However, while effective for some people, it has caused movement of these upper anterior teeth that can bear the full force of the device. Also, the device's small coverage does not work for people with a long centric or class 2 occlusion, as the jaw can slide back and does not even hit the device. Some people think that with only the anterior teeth in occlusion that the posterior teeth will over-erupt. Studies have shown this is not the case. In fact, posterior teeth need to be in disclusion for over 7 days before any permanent movement is caused. The GrindRelief PRO. This is a hybrid device, smaller than the full arch and larger than the NTI, with numerous other benefits. This device recognizes the benchmark effectiveness of midline pressure to reduce muscle activity, as the NTI has been proven to do. However, in this device, central pressure is created by a bar inside of a flexible, heat-resistant shell at the midline. The heat-resistant plastic is 0.2 of a millimeter thick, and as the patient bites down, the shell flexes and pressure is automatically concentrated on both midlines, the upper and lower at the same time. The shell is lined with thermoplastic, which is white, but clear upon heating to about 160 degrees Fahrenheit. The thermoplastic may be resoftened and refit as many times as desired, as the outer plastic shell is heat resistant. The device extends to the first or second bicuspid area, and preferably is formed on the lower teeth, although, if desired, can be formed on the upper teeth. Designed to be larger than the NTI, which covers about 4 teeth, and smaller than the full arch device, this allows a patient with class 2 bite or long-centric to still contact the device even when the mandible slides posteriorly. It is the most wearable, most patient-accepted device with the highest degree of success in treating bruxism that I have ever used in my many years of practice. I call it the right now 10-minute treatment for bruxism that so many patients need. Typically, my staff, assistant, or hygienist will make these devices after they call to my attention. I agree. I say, yes, that patient needs that treatment, and they make it in 10 minutes. I can't recall the last time I made one. You can charge a regular splint fee or a reduced fee and still make the same amount of money because of no lab fee, no multi-appointment procedure, and the patients are going to be happier. They will refer patients, that is family and friends, when they see how much this helps them. Since this is a device most people have not seen before, I think it's best to run through a brief demonstration of how easy it is to make this device, right at the chair. In the following video, my assistant Kelly will demonstrate how easy this is to make. Now Kelly has removed the device. See, it's clear. It needs to be totally clear. A couple of little white spots in there, but it needs to be clear. So she's folding the thermoplastic. This is critical. You need to fold that thermoplastic in to mold it into the shell, and that outer shell will stay, won't soften. The water, this is not boiling water. It's like about the temperature of hot coffee. Now watch this. She's going to flex. See how that tray flexes? That's what's going to happen when the teeth come down, and it will self-adjust at the midline. Now, this is Kelly's daughter, Dakota, and she's going to form this.
Line it up at the midline here.
Yeah, it's important to get that central bar needs to be at the midline.
I'm going to tuck out the thermoplastic in.
Border molding.
Border molding, yep.
Typically, she'll push that back against
then we'll
the lower
make it
front
flush
teeth.
in the back.
You can make it on the upper also, but most
finger.
people seem to like it on lower.
Okay. So we're lined up here. Go ahead and bite down for me. Just relax your jaws.
As she bites down, the focus will come on the midline, and as that flexing, the other teeth on both sides will push that down. It will self-adjust bilaterally, and the main pressure will be the upper and lower midline. That bar goes in the tray, so it hits the lower midline and the upper midline as she bites together there. Now, we're waiting. Typically, this takes about 5 to 10 minutes, and It's very easy to do. Kelly makes, I make very few of these. She makes the most of them here, and she does a great job with it. But also our hygienists, they point this out. Sometimes Kelly, your staff spends maybe more time with the patient than you do. A lot of times they'll find out, hey, that patient has a hard time opening. They've got tight cheek musculature. You've got notching here. It'll call it to my attention, and I'll confirm the diagnosis, and then they will go ahead and make this. And there's no lab fees. It's a one appointment thing. You can bill a regular splint fee. You can bill a reduced splint fee, or bill it as similar to the NTI. We bill a lot of times here palliative, which I think is undercharging, but the options, there's many options as far as billing. And since you want to have one appointment, and you don't have any lab fees, it's profitable. This is a great practice builder for us. And these people, if you don't help them, they're going to get an over-the-counter device, not going to be nearly as good as this. Now, Sarah, you have worn the full arch splint before.
Yes.
Now, how did that go for you?
I really hated the full arch. I couldn't really wear it.
Yeah.
Never worked for me.
Yeah.
I like this, what you've made for me, much better.
So we made the GrindRelief, which is that's the GrindRelief.
Yeah.
So we made that. Great. And how did that work for you?
Much better.
Yeah.
I can even talk.
Yeah, right. But it was still having some issues. I think it was still having some tightness, some problems. And so what then, Sarah? We made you this is an upper, similar to Invisalign, but can you place that in, Sarah? So we do this occasionally when we think we're pretty well there, but this gives her a little bit more vertical, a free glide on her excursions.
I had went to a previous dentist years ago, and I was clenching all the time, grinding my teeth, and I went in and I would get really bad headaches, and they just basically said to get the stress out of my life, which, everybody has stress. So I just didn't like the way that they went about that. So I decided to look for a new dentist, and I started coming here, and I loved them. And then when I started having issues again with headaches, my jaw, I came in and Dr. Pelerin decided to do the bite guard, and it really has saved my life, because my headaches would be like I would be in bed for a few days because it would hurt so bad. And it worked for years, my bite guard. And then when I had some extra added stress in my life, I started getting the headaches again and the jaw pain, and my husband said, you got to go back in. Something's going on. So I did, and immediately he knew what to do.
Yeah, we made the combination of the upper clear splint. She had it for a long time. The GrindRelief was working great, which the GrindRelief goes into the lower. I'm just going to show it here. But then when we combined it with the upper clear splint, it gave a little extra dimension, the free glide to the mandible. And within 3 days, what happened?
Yes. Oh, I felt so much better.
Yeah.
The headaches were gone. My jaw pain was gone. I was sleeping better. My husband was sleeping better.
Yeah. So I could have referred her to TMJ specialist, $5,000 or whatever it was, but I've had success. She's not the only one. Not everybody is this extreme. I only have to do, but most of the time the GrindRelief alone will do it. But sometimes I need the combination device to get somebody. And it wasn't she all of a sudden developed a TMJ issue. It was stress. And this is what happens to everybody today. Wonderful advice from the other dentist or assistant that you need to get stress out of your life. But how do we do that?
Yeah.
That's a little idealistic. In the practical world, you need some help.
Yeah.
We got it for her.
Yes. And I don't want to just take a pain medicine or even over-the-counter pain medicine because it wears off. That's just a Band-Aid. I want a solution to the problem. And for sure, this is what it was.
So there we are. We've looked at over a dozen symptoms of bruxism that dentists, hygienists, and assistants see all the time, and a comparison of the various techniques, devices available to us to treat this painful, stress-related malady. With these medically, economically, and politically stressful times, I expect many more of my returning patients to be stressed out and clenching. It is a growing problem, but we can break the sequelae by intervening with relatively low-cost devices that many patients always appreciate and which can help you build patient referrals and profits. Train yourself and your staff to interview and screen as best you can. Many will not accept the $600 to $700 full arch treatment. Many more will accept the GrindRelief PRO, especially right now. Otherwise, they will buy an over-the-counter device. Treat your patients, make them happy. They will refer friends and family. Samples are available. Just snap this QR code. Try it on staff members, friends, and family first. See how easy and fast it is, and then see how well most patients are helped by this device. I recently saw a new patient who had fractured tooth number 3 and 14 and had obvious wear on the lower incisors. I said, "It looks like you may be clenching and grinding." He said, "I do both." However, if I didn't ask, the chances are slim to none that he would have mentioned this. You have to ask your patients.